Hi, let's talk about the alveoli, ventilation, and respiration. In this video, we'll discuss the features of a lobule of the lung with an emphasis on the respiratory zone features and their functions. We'll discuss the key features of an alveolus, the cells which comprise the alveoli and their functions, and also discuss the respiratory membrane. We'll discuss Boyle's law in the context of ventilation and discuss the muscles which are involved in ventilation. We'll finally discuss the effects that smoking has on the respiratory system and what emphysema is. So if you recall, the respiratory system is broken down into two zones. The first is the conductive zone, and the second is the respiratory zone. So the conductive zone is for moving air in and out of the respiratory zone, and the respiratory zone is for gas exchange between the contents of the respiratory system and the cardiovascular system. So what we have here is the terminal portion of the conductive zone, or a terminal bronchiole, coming down and multifurcating into several respiratory bronchioles. These respiratory bronchioles are what host these sacculations of epithelial tissue surrounded by a basement membrane and capillary beds, or in other words, alveoli. These alveoli are comprised of two distinct types of cells. There are Type 1 alveolar cells, which are simple squamous epithelial tissue. So these are very flat, round, shield-like cells. And these are the cells which comprise the respiratory epithelium. These are the cells across which we are going to have gas exchange in and out of the capillary beds. Now, if you think about what a capillary is, it's basically just simple squamous epithelium with a basement membrane. And so what we have are two layers of simple squamous epithelial cells with basement membrane in between. And that's not very thick. It's only about 1/2 a micrometer in thickness, which is pretty impressive. Now, in sum total, though, if you take up all of the surface area of these type 1 alveolar cells, or of the respiratory membrane, it's about 70 square meters. So 70 square meters, for those of you who aren't metrically inclined, that's about 4.5 parking spaces. So a parking space is about 15 square meters. The other cells which are present within the alveoli are type 2 alveolar cells. Type 2 alveolar cells are more cuboidal in nature, and they tend to secrete a surfactant which helps to diminish the surface tension on the alveoli, to maintain the patency of the alveoli. And also present are macrophages. So macrophages are derivatives of myeloid stem cells. And these are derived to consume any foreign material which makes its way into the alveoli. And they have earned their the moniker dust cells, because they would consume any dust particles that you breathe in that would escape being trapped in any of the mucosa from along the conductive pathway. Now keep in mind that the capillary beds here are part of the pulmonary loop, and the pulmonary loop is fed by the pulmonary arteries, and so those pulmonary arteries are going to be tracking along the bronchial tree, and as the bronchial tree gets smaller, as do the arteries, they are shrinking in size to the level of arterioles, and so you can see here this pulmonary arteriole is carrying very unoxygenated blood out to the capillary beds, and then this pulmonary venule is carrying very richly oxygenated blood out towards the hilum and the pulmonary veins towards the left ventricle of the heart. Now, much of the lung parenchyma can receive oxygen through this system, but there's also a separate set of arteries which supply the lung parenchyma called the bronchial arteries. Bronchial arteries are going to serve the lung parenchyma as well as the bronchial tree. There are generally 3 of them that come off of the thoracic aorta, 2 left and a right. The right is highly variable with respect to its origin, and it typically comes off one of the left bronchial arteries. So ventilation is the movement of gases in and out of the lungs, and we'll just call those gases air for simplicity's sake. All of this is described very well by Boyle's law, and if you don't recall Boyle's law from your chemistry or your physics classes, it's pressure times volume equals a constant. And so by rearranging this, we can see that pressure and volume are therefore going to be inversely proportional to one another. So whenever volume is quite large, pressure is quite low. Whenever volume is quite small, pressure is quite high. So you can intuitively think about this, thinking about a certain amount of gas in a large canister versus a small canister. You know, the large canister, the pressure would be very low. The small canister, the pressure would be higher. Now, air is going to move in and out of the lungs accordingly. So the lungs are within the thoracic cavity. The thoracic cavity is a bony cage with a diaphragm that separates it from the abdominal pelvic cavity. And what happens with respiration is the diaphragm displaces, and as the diaphragm contracts and displaces inferiorly, the volume of the thoracic cavity increases. By increasing the volume, pressure decreases. Pressure then runs from outside, following the conductive pathway, into the lungs. And as the diaphragm relaxes, which is a passive process, then volume is going to decrease, pressure will increase, and then air can flow out of the lungs once again. So that's just typical diaphragmatic breathing. There are also accessory muscles of respiration which can aid in the contraction or the expansion of the thoracic cavity. Probably the major muscles that we should consider for sort of forceful respiration would be the intercostal muscles. Now, there are 2 types of intercostal muscles. There are actually 3 types, but we'll just dumb it down to external and internal intercostals. We'll forget all about those pesky innermost intercostals because they're following the internal intercostals. So let's keep this nice and simple. So the external intercostal muscles, as you can see here, they have more of a lateral approach, and what happens when they contract, they pull the ribs upward and outward. By pulling the ribs upward and outward, the external intercostals, as they contract, are going to increase the volume and therefore decrease the pressure. So external intercostal muscles are going to be very helpful for forceful inhalation. So forceful inhalation, external intercostal muscles are your muscles. For forceful exhalation, you have the internal intercostal muscles. Internal intercostal muscles, when they contract, they pull the ribs downward and inward. So the internal intercostal muscles, they're going to decrease volume and therefore increase pressure. So they're going to be more involved with forceful exhalation, or the movement of air out. Now, there are additional muscles that can help shape the thoracic cavity of volume in a variety of ways. The sternocleidomastoid muscle, the scalene muscles, anterior, middle, and posterior scalene muscles. Sternocleidomastoid attaches to the manubrium and clavicle. When they bilaterally contract, that's going to increase the thoracic cavity ever so slightly. Scalene muscles, rib 1 for anterior and middle, rib 2 for the posterior scalene muscle. They're going to elevate the first 2 ribs. So both of these are going to be very helpful for forceful inhalation. And then pectoralis minor. Pectoralis minor is, when it contracts, going to elevate the ribs that it attaches to and pull them superiorly and outward, basically the same function as the external intercostal muscles. So in terms of forceful exhalation, the abdominal muscles. So the various muscles of the abdomen, so rectus abdominis, external abdominal oblique, internal abdominal oblique, and transversus abdominis, can all put pressure on the abdominal cavity. Whenever pressure in the abdominal cavity increases, that's going to exert pressure on the diaphragm. And by putting pressure on the diaphragm, it can further put pressure on the thoracic cavity. So those abdominal muscles are involved with forceful exhalation. So you should do yourself a favor. Put your hands on your rib cage and just breathe for a little while. Just nothing special, just diaphragmatic breathing. And then take a very deep breath in and feel the expansion of your rib cage. Let it out. Another deep breath in, and then put a hand on your abdominal muscles. And then if you're alone in a room, that's great. Go ahead and cough. If you're around people, do the waiter's cough. Cough in your sleeve and do the and then feel your abdominal muscles engage with a cough, and understand how that force applied to the abdominal pelvic cavity is going to also exert force to the thoracic cavity. Now, smoking rates worldwide traditionally have been quite high. We see, elevated smoking rates in many different nations, although some of them are declining as public health awareness increases and as other forms of nicotine delivery also increase. But it's important to understand the effects that smoking has on the respiratory system. So there's just a few things that I'd like to discuss. Nicotine is going to restrict terminal bronchioles. So it's going to constrict the proximal portion of the respiratory pathway. And by restricting that, you're really limiting the amount of air exchange that occurs with ventilation. With smoking, there's also combustion, and with combustion there's carbon monoxide, and we know that carbon monoxide is a competitive inhibitor of oxygen at hemoglobin. In fact, hemoglobin has an affinity for carbon dioxide that's about 250 times greater than that of oxygen. So, you lower the blood's ability to move oxygen with smoking. There's also increased bronchial mucus production and mucosal edema, and this can be problematic because this increased bronchial mucus is going to do two things. One, it's going to narrow the lumen of the conductive portion of the respiratory system, and that's problematic. But secondly, over a long enough period of time, this thickening of the bronchial mucosa has an effect on the epithelial lining of the conductive pathway. So within the conductive pathway, there's the mucus elevator. So this is the ciliated pseudostratified columnar epithelium that helps to move mucus from the distal to the proximal portions of the airway. So it elevates the mucus from the bronchial tree up into the laryngopharynx, where a person can then swallow it in the night. But over a long enough period of time, through smoking, you lose this mucus elevator, and it's converted to stratified squamous epithelium. And so, these substances don't get cleared from the lungs, and this is the basis behind smoker's cough. Smoking also destroys some of the elastic fibers of the lungs, which we'll discuss shortly, leading to issues in rebound of the alveolar walls and an inability to efficiently move air. So if we look at some of the lungs here, we can see some deposits of tar. We can also see some upper lobe emphysema, or an expansion of the alveolar sacs, or the obliteration of some of the alveolar walls there. And in addition to all of this, smoking is going to elevate a risk for lung cancer. Now, lung cancer is one of the leading causes of cancer deaths in the U.S., and about 85% of lung cancers are smoking related. So in terms of risk factor, smoking elevates your risk factor of various lung cancers between 10 to 30%. And this can further be multiplied if an individual is consuming alcohol at the same time, although that multiplicative risk factor tends to affect more oropharyngeal cancers. So if you're going to smoke, don't drink at the same time. Separate your vices. So some of the more common lung cancers, these are carcinomas, and we're not limited to just these types, but various bronchogenic carcinomas, adenocarcinoma. This is cancer of glandular epithelial tissue. This is the most common type of lung cancer, keeping in mind that carcinomas are malignancies of epithelial tissues, and carcinomas tend to spread lymphogenously. There's also squamous cell carcinoma. This is of the larger bronchial tube epithelial tissue, as well as small cell carcinoma that relates to the epithelial tissue of the primary bronchi. Emphysema is also an issue that can come with smoking. Emphysema is a form of COPD, or chronic obstructive pulmonary disorder. And with emphysema, there's a destruction of the alveolar cell walls. And so, this might be what, typical lung parenchyma looks like, but with emphysema, you start to get these honeycomb appearances as the alveoli combine with some of the smaller air tubes. You can also see this is the visceral pleura here. There are some subpleural bullae here, or expansions of air pockets throughout here, and these can be particularly dangerous, because if ever there's a pneumothorax, the walls here are very weak, and it can also blow through the wall of the lung as well. And so with emphysema, you lose a significant amount of surface area for respiration. You lose the lung's natural ability elastically recoil to move air out. And so people have to work very hard at ventilating. So they're taking very deep breaths in and out, in and out. It's more forceful inhalation, exhalation. They can't just rely on their diaphragm. And so not only are they getting lower O2 sats, but this constant, employment of the accessory muscles of respiration can remodel the rib cage and give more of a barrel-chested appearance. And with things not moving as efficiently, and not just air, but mucus and things accumulating within the lungs, emphysema can be a precursor to lung cancer as well. So that leads us to our assessment question of the video, which is, with which process of ventilation do the scalene muscles contribute? Is it A, exhalation, or B, inhalation? Well, let's think about those scalene muscles. Those scalene muscles originate on the transverse processes of cervical vertebrae, and they come down, and the anterior scalene and the middle scalene insert on rib 1. The posterior scalene goes down and inserts on rib 2. So when the scalene muscles contract, they're elevators of rib 1 and 2. By elevating the ribs, that leads to an increase in volume, which leads to a decrease in pressure, and that would be for a muscle of inhalation. Thank you very much for your time.